clinical and psychosocial perspectives. Disorders of sexual development is an umbrella term approach. The common clinical presentation: absence of genitals at birth, that is aphalia or vaginal agenesis, underdeveloped penis or clitoromegaly, then hormonal imbalances, electrolyte imbalances which are seen in the form of salt wasting syndrome commonly, starting menstruation at an unusual age, undescending testes, and severe hypospadias, that is penoscrotal or perineal hypospadias. What causes the disorders of sexual development? Mostly genetic mutations, which may be inherited, that is from parents to offsprings, or spontaneous, which has no cause, idiopathic. Then developmental issues during the fetal development, hormone insufficiency, and exposure to the certain hormones or medications during pregnancy. According to the scarce and the dispersed literature, many adults who have DST, they are probably at the increased risk of various cardiovascular, metabolic, neuropsychological comorbidities. Now management, it depends upon the severity of the symptoms. First is the hormone replacement therapy, which is important for sustaining life, and in case of the osteoporosis, steroids are given to the patients. And hormonal replacement therapy, second most common use is for development of the secondary sexual characters, fertility potentials, and psychosocial milieu. Okay. Next is the reconstructive surgeries. Unless it is medically necessary, then only these should be performed now. Irreversible procedures. Until children are old enough to make their own informed decisions, these are as per now rules. People with mild DST symptoms, they may not require treatment at all. These are the spectrum of DSTs. Here one can see first this one is a patient of CEH, congenital adrenal hyperplasia with clitoromegaly. This is again patient of the congenital adrenal hyperplasia. This is this one androgen insensitivity syndrome, again androgen insensitivity syndrome. As there is paucity of the information or data in our region, so this study is taken into consideration, and the objective of this study was to assess the clinical and the socio-demographic profile of patients with DST and their family members in the Jammu region, psychosocial profile of these patients and their family members. Study design, it is a retrospective and observational descriptive study. This was done in the Pediatric Surgery Department of Government Medical College Jammu and associated hospitals. Study period duration is approximately 13 years from 2010 to 2023. Records of the children from birth to 18 years who were registered in the Pediatric Surgery Outpatient Department with diagnosis of the DST, they were included. Inclusion criteria was patient of DST from birth to 18 years of the age, and patient they are assessed by the single pediatric surgeon. Exclusion criteria: DST with the syndromes, they were excluded from the study. Those who have not given consent, and patients with the bladder extrophy or cloacal extrophy, they were excluded. Following parameters were assessed: socio-demographic variables, clinical examination along with genitalia examination, investigations, and psychosocial assessment. These were considered. In socio-demographic variables, age at presentation, assigned sex, residence, socio-economic status, caste, ethnicity, family, sibling, and other associated anomalies, they were considered. Clinical examination involved dysmorphic features, pigmentation, gynecomastia, and on genital examination, the presence of severe hypospadias with caudy, palpable or impalpable gonads, asymmetric genital folds, these were considered, and presence of Mullerian structures. Investigation included the chromosomal analysis like karyotyping, then radiological investigations like the abdominopelvic ultrasonography, retrograde urethrogram, MRI. All these investigations are not done in all the patients. These are according to the time we are required. So these are as from the retrospective from the retrospective records, we have taken all these investigations into considerations. Hormonal evaluation, both basal or stimulated hormonal levels and electrolytes. Psychosocial assessment, questionnaire served to all the participants, formulated by our own experiences in the form of 10 questions and translated to the local languages in Hindi, Dogri and Urdu after pilot testing on 12 patients, and it included level of acceptance, family relationships, social relationships and the future expectations. Now the results. Total number of the patients in our study were 44. Age distribution was 14 in infancy age group and 30 was 1 to 18 years of age. Then karyotyping, genetically male 46XY seen in 27 patients and genetically female 46XX seen in 17 patients. Now this is the distribution of the DST. From this 46XY DST, in this subclassification, partial androgen insensitivity syndrome was seen in 21 patients. Complete androgen insensitivity was seen in 2. 5-alpha reductase deficiency was seen in 2 patients. Persistent Mullerian duct syndrome seen in 1 patient and pure gonadal dysgenesis seen in 1 patient. And 46XX DST, these were seen in the 17 patients. Family history positive in 7 patients. Consanguinity was seen in 10 families. The psychosocial assessment of the parents and the patients, these were seen in the form of insecurity, anxiety, guilt, worthlessness, intense distrust in the society, fear about marriage, job and acceptance. In discussion, in our study, we observed there is predominance of XY, which is mostly inconsistent with most of the studies, as congenital adrenal hyperplasia is considered in most of the studies, but here and also in the AIMS MPH, that is XY, these are most commonly seen. The cause may be misdiagnosis, biases and socio-cultural factors. These cannot be ruled out. As expected, majority were diagnosed later in the pediatric age group owing to lack of awareness, low degree of clinical suspicion and lack of diagnostic facilities and also social stigma. Moreover, it is difficult to comment on the occurrence of other DSTs because of the low sample size. In conclusion, there is predominance of DST, genetically male was seen. Psychological trauma was equally pervasive among all the patients and their families. A patient-centric need for mitigation or treatment should be the prime objective. Also, the management has to be individualized according to the social, psychological, cultural concern along with the consent of the child and the family should be considered. These are the few photographs. These are the patients who are already operated few years back only. This first is the patient of the complete androgen insensitivity syndrome, where gonadectomy was done at the age of about 1 year, and now she is studying in the 11th class and on the estrogen therapy. Second is a case of the second photograph. It shows the patient of congenital adrenal hyperplasia. He came late at the age of 14 years. All the consequences, all the things were discussed with the parents, and they wanted to rear him as the male only, continued the patient with the male only as he was already reared as a male. So in first stage, pan hysterectomy was done and cordy correction, and in second stage this urethroplasty was done. Now he is going to marry. And this third photograph depicts the true hermaphrodite, where ovotestis both were seen on the one side, and on the other side small streak structure was there, and patient is again reared as a male only. And this is case of the partial androgen insensitivity syndrome, where stage procedure was done. And in the end, I want to say it is a trust, compassion and empathy which recognizes the value and dignity of every individual, and these should be taken into considerations while managing these patients. Thank you. kindly give their expert comments.
Hello, hello. Very nice presentation, Dr.
Thank you, sir.
Lucky. And I want to ask that how do you counsel the parents when patient first came to you?
Sir, mostly as as this is a retrospective study, when the patient comes to us in the OPD, they have already referred from the pediatric surgery or elsewhere. Then we discuss the condition with the patients, not in the first session only ki this patient is this one and not these like this one. Step by step, uh,
After going through investigation?
no sir, prior to investigation also counseling of the patient. This can be accessed already because they read them as a male or female already. 2-3 patients they were already read, like in case of the androgen insensitivity syndrome. Child was having both the gonads, testes were present, and they read her as a female only, and came with the complaints of the hernia. And after investigation, karyotyping, retrograde ureterogram, all investigations were done. Then these choices were given to the patient because child was in the early stage only, 1.5 year. And after discussing with them, like child is XY, having both the testicles, what do you want? Because in Muhammad and in Muslim family, because I have seen these patients of consanguinity mostly seen in the these families. There are certain areas in Jammu like the Punch, Rajouri, Srinagar is not included because it is done only in the Jammu province only. And these areas they have the consanguineous marriages. Now there is a social stigma also. So we ask patients, what do you want? After doing all these investigations, then depending on the choice of the patient and whether it is feasible for the children or not, accordingly it was decided. Like the other patient who came to us at the 14 years of the age with congenital adrenal hyperplasia, he was already on the drugs, this one steroids for salt wasting.
But I think recently guidelines are...
Yes, sir. These retrospective study. Now we have lot of patients, but we are waiting. First thing, and sir, actually I am doing the psychology counseling in psychology only. So we give choices, ask patient, and I think it is only the faith between the doctor and the patient or family. So we will wait, and they are in the waiting period now only for the last 1.5 year.
Since we are the most of the subject sitting here, so because initially things we have learned from. There are a few things actually in this part of it. Actually, it's very difficult to change the assigned sex which has been already assigned to the parents. It's very difficult.
Yes.
I just want to ask you two things. One is that you said that that one the photograph you showed us is in 11th. You said it has undergone this thing gonadectomy at the age of 1 year on estrogen therapy. Usually we avoid it till the age of 18 or 19 years.
Now he is 21 years.
That's but you say it has been removed in the early childhood at around 1 year of age. Now the patients, the person.
The first patient complete this partial androgen insensitivity syndrome.
Yeah, yeah.
He was operated at the age of 1.5 year, but
That's
no gonads were removed.
okay. Then second thing you said the CH patient who has undergone the.
Who has undergone surgery at the age of 40 years of age?
No, just this.
Yes, sir.
The second patient of CH
Yes, sir.
who has now undergone male genitoplasty.
Yes, sir.
Okay. So you said the patient is going for marriage. That's my point.
Sir, actually, last year, some ethical doubt was there whether he has to marry or he can marry or not. But I think they are there personally.
We have male CH patients. So just to update you, we have male CH patients who are married. Yeah, it is 46XS. The male genitoplasty is done. They will never bear children, but they can get married. So the medical legal question here is, should they tell their spouse? Usually we leave it to families to decide for that. But that is the main question that they come to ask us. And those who tell, they are left unmarried. Even the normal CH female patients, nobody is ready to accept. And the main problem with CH girls also, when they grow up, if they have hoarse voice, many of them have been rejected 2, 3, 4 times, even after I get कि आपकी आवाज़ ठीक नहीं लगती, whatever. So there are many things in society. I want to ask you, do you have the Hijra community in Jammu?
Yes, sir. Yes, ma'am.
They are there on the streets like in Delhi?
Yes.
Thank you. You don't have in Kashmir. You don't have the Hijra community in Kashmir. But that's to be a difference.
Many. I mean, this thing, what do you call it, losing your, I mean, mediator between the two families, or arranging their marriage. Yeah, that is. But they are not on the roadsides. No.
So, know what's the problem?
So most common complication which is seen in case of CH is the osteoporosis, because they don't take medicines regularly, and otherwise these people are very simple people. DST, mostly DST people, they are very simple.
Good morning. Lucky, I wish to compliment you for taking the interest and taking care of so many
Thank you, sir.
these DST cases. Not many people are familiar with the system or to diagnose them, investigate them and treat them. I think you deserve a very special compliment.
Thank you, sir.
And I saw that your incidence for consanguinity reported is 22%, almost 1/4 of them. You know, in the last series from Delhi, we had only 10%. And consanguinity, of course, is one of the main reasons for that. I may share some information from the Middle East, where this condition is also quite common. And as per their Sharia law, the chromosomal sex is not to be changed. So they maintain the sex of the child according to the chromosomal sex. But here, I think family are most important. And as you rightly pointed out, you have to sit with the parents and the patient, if he is about 10, 12 years and if he understands, and only then the final decision rests. Because the child must be acceptable in the family first,
Yes.
then in the society, and they have to live their life. The support from outside is very limited and we cannot depend on that. So whatever family wants, that we should follow the lineage. We have few patients who are now 40 plus who have been treated for DST, and recently there was a girl whom I operated several years back, and CH patient, and she has born 2 children now, perfectly under control with steroids, and maintaining very low dose, but she's fine. Is one of the examples that CH is the only group that they can be fertile, they can lead a normal life. She is actually a professor in BHU at the moment, and she's leading a very happy, healthy, good life. So many of them are there at the moment. Thank you very much once again.
Thank you, sir. Thank you, Chairman.
Thank you, ma'am, for sharing your expertise with us. Big round of applause for Dr. Akita. And now, with our chairperson's permission, moving on to our next session titled PRP Innovations. Is it really a wonderful fluid? To speak on this title, it is my privilege to welcome on stage our speaker, Dr. Avinash Jadhav, Additional Professor, Department of Pediatric Surgery, AIMS Jodhpur. I now hand over the proceedings to our chairperson.
Good morning, respected chair, respected seniors in the audience, friends and colleagues. Good morning, I am Dr. Avinash, additional professor from AIMS Jodhpur. My topic is PRP innovations. Is it really a wonderful fluid? So this is a debatable topic in itself. Was supposed to be a debate already, and that's what I am going to present both the sides of the table. So what is PRP? It's a autologous plasma which is concentrated and has a higher level of higher concentration of platelets along with plasma and its contents. So it has many growth factors along with it in the plasma. And there are various types of PRPs that are used. One is a platelet-rich plasma, the other is a leukocyte-rich, platelet-rich, the other is platelet-rich fibrin, and leukocyte-rich platelet fibrin plasma. So these are the various components that can be used in these forms. So these are the growth factors which are there in the PRP, and these are the benefits of these are supposed to be exploited in our clinical use that is being implemented now. So there are various growth factors. There are vascular growth factors, there are myogenic growth factors, and there are some immunogenic factors also. So these are supposed to be the factors which are giving the PRP its benefit. So how do we do it? Then now when we come to PRP, from pediatric surgery point, what I want to emphasize on a fibrin, platelet-rich fibrin, which is it's like a sheet which is used at various places. So the technique is the difference is in the way it is centrifuged, and that gives us the PRF from PRP. So PRF is a concentrated preparation which contains 4 to 9 times of the basal platelet count, and it was first introduced for dental surgery application, for the oral maxillofacial surgery applications, and then it has been exploited in other fields also. So it promotes healing by various growth factors that I have told you, like cytokines and growth factors. So the most common use for PRF in pediatric surgery is for hypospadias repair that has been reported in the literature. So as we know, hypospadias is a technically demanding surgery, and its complications can be troublesome at times. So everyone is trying to find out ways to minimize the complications in this surgery. So one of the things that has been explored is PRF now. So how do we do it is we collect the blood 5 to 15 ml depending on the age and the volume that we can get from the patient. It is centrifuged, and then we get a fibrin, a gel-like consistency like material, which is a platelet-rich fibrin. So this is the equipment and the setup that we need. Blood sampling to be done and then centrifuge, and this is the picture F shows is the final thing that we get. It's a quite robust, thick membrane. So where can we use PRF apart from pediatric surgery? As we all know, it has been used in hair loss, in alopecia, treatment of alopecia, arthritis, to promote wound healing in patients for alveolar clefts, as I told you, in OMF surgeries, and spinal conditions like neural tube defect surgeries, and pyramidal sinus to promote wound healing. So now coming to our area of interest, that is the role in hypospadia surgery. So this paper had come in 2008, where it was a preliminary experience of the group, where they found there was no statistical difference in the results when with or without PRP in the fistula rates and healing. However, the literature it keeps coming time by time, and now in 2021, Egypt group has published a paper. According to them, PRP was found to be effective and helpful in reducing the overall complications as well as the fistula rates in patients of distal hypospadias for tape repair. This paper again came from Egypt in 2018, and it showed the benefits of PRP in patients with hypospadias for tip repair. Again, this was a single case report which had shown the use of PRP. So there was a need to review it, the actual results. So systematic analysis was done by an Indian group only on the use of platelet-rich concentrates in hypospadias repair. Of all the studies, they found 4 studies to be eligible for the criteria, and they were included. And the results was that there was no significant difference in the fistula rate, and however there was a significant difference in other complications like wound infection, meatal stenosis, and total complication rate, showing benefits towards the PRF group. This paper was a comparative study between use of PRF as a second layer, as a waterproofing layer, and a usual Darkus flap. So in this case, they in this study they found that the overall fistula rate, there was no significant difference, but there was PRF was more beneficial to avoid complications like meatal stenosis and wound infections. Now coming to other indications of PRF other than hypospadias is meningomyelocele repair. Not much, there are not many articles available, but those which are the one which was most significant was this article, which showed that they had a group of 40 patients. They had grouped in 2 equally divided groups. So they found out that CSF leakage percentage was less in PRF, the platelet-rich PRP group. Skin necrosis was less in PRP group, and hydrocephalus rates were less. So overall, what they found out, the meningitis rates were less. Sorry. So overall, what they found out was the CSF leakage. PRP helped in preventing CSF leakage, meningitis, and preventing the post-op skin necrosis of the flaps. Then few indications where it has been used. It's not actually pediatric, but it can be extrapolated in our setup, in our field also, is use of PRP in cases to close tracheoesophageal fistulas. This was this was an iatrogenic injury which had led to a tracheoesophageal fistula in an old person, and then they had tried to repair the tracheoesophageal fistula with flaps, 2 surgeries 2 or 3 times, but then they found PRP to be helpful. When they used it, it healed. Similarly, this is a single case report of esophageal fistula following a surgery in a child, which also healed because of with the use of PRP. So to conclude, PRP or PRF has a wound healing role in the wound, definitely has some role in wound healing. It is rich in growth factors and immunogenic factors, which helps in contributes to help in improving the surgical outcomes. The use of PRF has been attempted in hypospadias, in MMCs, and esophageal surgeries from our perspective. However, we need larger studies to actually establish the mechanism, the way it helps, and actual results if there are any benefits. Thank you.
Very wonderful session, sir. So there are actually basically two main challenges what we feel for this PRP and PRF fibrin. The main challenges are one part is the quality control part. See means whether that equipment is standardized or not, whether we are having the proper RPM and that time that is proper for that thing, for proper yield. Apart from that, whether there is some contamination or
Yeah.
not, the contamination part is very important. And there one more thing I want to add is the that transmitted infection screening part. That is also important. That should be also be done while having this when we are collecting the this blood from the patients. So we should be means doing that thing also. Means actually most of the studies they don't do this thing. So apart from that, the other thing is regarding these studies. The studies we are seeing these days actually they are very smaller studies.
Yeah.
So basically for a conclusive data, so we need bigger studies and standardized ones. So that will I think make more impact in the future for this PRP and PRF.
Yes, sir. Yes, sir. We are facing the same issues that you are telling us. We are having a thesis in our department in hypospedia, role of PRF and hypospedias. The same issues that you have said, that the logistics basically maintaining the sterility of the PRF that we receive from the blood from wherever we are getting centrifuged. We are using transfusion medicine. We are getting help from the transfusion medicine, but OT is far from the transfusion medicine unit. So these are the problems. Maintaining sterility is one of them. Again, quality of PRF every time is not achievable. I think that you have pointed out very well the technical issues, the RPM at which it was done, how it was done. Those are there, sir. Those problems are there. That's why it's still a very debatable topic. Some papers are saying it's a wonderful thing. Some papers are not agreeing to it. So we do need bigger studies and actual data what is happening.
The main thing is standardization. I think
Yeah.
many of us are not standardizing the procedures.
The way it is.
So that is the main thing. I think we should be first standardize the
Yes.
procedure. After that we can use after seeing the yield and the growth factors in the platelets. After that we can use this thing. I think ma'am can elaborate more.
Hi, good morning, sir. Ma'am, do you have any question?
I'll talk up.
You say then I'll speak. No,
You have.
Okay. Sir, I would like to first of all congratulate on your this presentation because this is such a controversial topic. But what I feel in the house is that it is most important to first of all establish what is the best part of the therapy. Because platelet-rich plasma has got different variants, as you rightly pointed out. We have PRF, we have PRP, we have leukocyte depleted, we have leukocyte rich. So first of all, the standardization of the technique, as Dr. Sushant pointed out, is very important. So what is your experience? I would like to ask, what is your experience with this? Have you standardized or compared PRF with PRP first of all?
No, ma'am. This is the just first study that we are doing. So first we have started with PRF because we need a film, a membrane
Okay.
that will act like the second layer or cover.
Okay.
So we have not used PRP anywhere yet.
Okay. So I feel for PRP is just such an investigational therapy from the point of view of therapy at this point of time. It is still not approved by FDA as of now, and wherever we have to use it, we have to prove as per our results. So what I would suggest is, sir, apart from doing this, you should also go for the growth factors to have a comparison. And as far as Dr. Sushant told you that standardization of the technique is very important because even if you are manufacturing PRF at different speeds of the centrifugation as well as at the different temperatures, we get a different yield of the growth factors. We also had one paper on this, the PRP at different times and centrifuge speeds. It gives you a different sort of growth factor yield, and which might be different for all different conditions. So I think the standardization of the technique between PRF and PRP is most important. And then one part like Dr. Sushant highlighted, the viral screening. Because in my previous experience, what we were doing, most of the people, they just go for the PRP or PRF without screening. Though it is an autologous product, we do not know what is the viral status of a person. And the clinicians are very much afraid of telling people what is the viral status. And sometimes what happens is that आपने उसको PRP या PRF के इंजेक्शंस लगाए and later on that person turns out to be seropositive. He will come and turn up like everything happened because of your technique. So
Yeah.
baseline viral markers are very important. I feel most of us are doing the PRP and PRF therapy without keeping in consideration that viral baseline markers are like the best thing. Second is the sterility, as Dr. Sushant pointed out. The thing is that we have a very narrow time margin. जब हम बनाते हैं, हम देते हैं, we do
Yes.
not have the time to get the sterility. But at least for the invasive procedures, like for osteoarthritis, जहाँ पे भी हम invasive कर रहे हैं, we should always go for the sterility. Even if it comes up to be positive later on, we can give them the antibiotic prophylaxis. That is in the best interest of the patient. Otherwise, we'll land up into something which is medical-legal.
Yeah, ma'am. Coming to your first point about viral markers, again I am venturing into a slightly controversial topic. As a protocol in our institute set up by the OT team,
Yes.
viral markers are done by for all the patients who are undergo surgery, any procedure in the OT.
Right.
So we do have viral markers for our patients,
Right, sir.
but yeah, you're right, that has to be done specifically.
Because this is my personal experience. We had one patient undergoing a PRP therapy for the hair loss, and when we did his viral markers, he turned out to be like hepatitis B positive. Then it was a clinical dilemma both for the clinician as well as for us, and he was an employee at the hospital. So whether to tell him or not that you are positive or not, that's like something very important. I think we should all look into this thing, this aspect of this.
Yes. Thank you.
Yes, ma'am, that is there. But
Why viral markers? I couldn't understand, sorry.
I'll
But
tell you
if
one
post
thing,
op
like
the patients.
whatever invasive, like you are doing an invasive procedure on a patient. Tomorrow, if he turns out to be seroreactive, he might be in the incubation phase or early phases of an infection. He might say that this thing happened because of your invasive procedure or the therapy you did. So it is for your benefit and your safety that you do these viral markers. That holds true for all the surgical procedures also. And I believe PRP is an upcoming therapy, so we should all be like very careful while like doing these procedures, because baseline viral markers are important for any invasive procedure. If you do not
It's safe to do them,
Yes, yes.
even if you are using the patient's own blood for the.
And this might come as a surprise to you, madam. Though we are using an autologous product, even if you infuse an autologous product, there are chances of getting an allergic or hypersensitive
No,
reaction. Yes. So you should always screen, at least for the viral markers. This is my suggestion.
Ma'am, one more point to this. Actually, what we do is, although we use this sterile containers, vial containers for this thing, we use acid vials for that are completely sterile. But we don't know, maybe sometimes actually they think that is not a sterile. Maybe patient is thinking that the containers or the materials you have used, that is not a sterile. Okay, so they might think that the infection they have acquired is from the.
And it's a biological product. I must always caution you all that before using any biological product, it is always mandatory, and you should always sure that it is sterile. Thank you so much. Anything, sir?
Lot of debate on this topic. It's a new topic, not so new though, new for pediatric surgeons, but it's been there and it's in here to stay. I've been attending many conferences and we have the first experience of using it in 2002 at PHU. My colleague Dr. Vittal had a thesis on this. So we used to make it in the theatre. The centrifuge machine has to go in the theatre. And of late, attending so many conferences on PRP, and I've also used it many times in many of my patients for hypospadias, neonates. It's autologous, there is no problem, but you have to go ample and make sure it is sterile. Ready-made vials available now. They cost 2,000 rupees. Just put the blood. You have your centrifuge right there and then, and inject from the other side. You need to send it anywhere outside. So this is what is being used by orthopedicians. They all have it in clinics. And cosmetology, you all must be knowing PRP is
Yes,
now. All models are using it every month. They get a PRP facial. So it's there to stay. The gynecologists are using it for vesico-vaginal fistula where it is there. The difference is that I do not inject in the tissue. They are injecting inside the tissue. We just leave it as a fluid there so that whatever needs to be given, it's taken care of and the rest is thrown off.
factors. So if you have a neonate who has an ulcer, like we had a patient of ectopia cardia, which we had operated, it really healed well. DSD heals very well. So elderly patients with DSD, they tend to have infection in the perineum. You put that, it heals very well. Anorectal fistula heals very well. Pilonidal sinus, as you said. So if there's any non-healing wound, PRP is good. You can relieve it as a fluid for safety. I'm not sure why they inject it. The others are injecting, I'm not injecting yet. So maybe injection can cause all those issues because the needle sterility is also at a question. Your point is well, then we should do that. But as pediatric surgeons, we are not used to getting occurs for neonates and children.
I'll add to that point, ma'am, why they are injecting, because there's a like conflict of interest in the literature also. If you go, some people say that we should inject the activated PRP. For activation, they use calcium chloride or kaolin. Another procedure of activating this PRP is injecting, because when you create a local tissue trauma, the platelets itself, they got activated. About the other thing which you said, that there are commercial vials available. The only problem with the commercial vials is that you cannot standardize the procedure. See, at least like my platelet count would be different, yours will be different, and all the people sitting in this hall would be having a different baseline count. What we need is a minimum 4 to 5 times the yield of the platelet with the minimum growth factors. I'm telling you, there is a dearth of data which says PRP is useful in all the possible indications. Yes, it is a form of regenerative therapy. It has to come beneficial to all of us because it has a lot of mesenchymal stem cells, it has got the peripheral blood stem cells, and apart from that, it has got growth factors also. It is going to be beneficial. But when I talk of a standardized, why this PRP therapy from the last 10 years has not been become a standardized form of therapy? Because we do not have a standardized form of data. If you go for the commercial vials, they might look cost effective to you.
So each person who's using it is standardizing it in their own way, and then some people are also sending samples to see how much is there. When you give a...
It's not happening. Had it been there, it had been there, though it had already been approved as a form of therapy. It is still investigational because of this part. Though there is a conflict of interest and a conflict of data. Yes, ma'am. Yes. Sir, sorry. Yeah, I think we must conclude it on all the questions, and the controversial thing we might take it later on the lunch or the tea session. Thank you so much, Dr. Avinash, for a wonderful session.
Thank you, Chairperson.
Thank you so much, sir, for this enriching session on PRP. And I express my gratitude to all the respected chairpersons for ensuring smooth conduct of the session. As a token of gratitude, we would like to felicitate our speakers. May I now request Dr. Latal Gupta on stage, please. I request Professor Dr. Atul Kumar Meena sir to kindly felicitate Dr. Gupta. A round of applause, please. May I now request Dr. Avinash Jadhav on stage, sir. I request Professor Dr. Atul Kumar Meena sir to kindly felicitate Dr. Jadhav sir as well. Thank you, sir. I now request Dr. Urvashi Kotwal and Dr. Sushant Kumar to kindly felicitate Professor Dr. Atul Kumar Meena sir. A huge round of applause, please. I now request Professor Dr. Atul Kumar sir to kindly felicitate Dr. Urvashi Kotwal ma'am. Sir, I also request you to kindly felicitate Dr. Sushant Kumar. Thank you, sir. We will now move forward to our grand session of the Upadhyay Gupta RIPS Oration 2024. To preside over this session of oration, it is my privilege to welcome Professor Dr. D.K. Gupta, Professor and founding member of RIPS and ex-head of the Department of Pediatric Surgery, AIIMS New Delhi, to kindly come on stage, please, sir. I request could you please come on the stage and sit as the chairperson?
Dr. S.K. Biswas and Dr. Nisar Bhatt can also join us on stage, please. Can you have the mic and Dr. Nisar's slide? Yes, sir, we should. It's a proud privilege to announce the Upadhyay Gupta RIPS Oration 2024, which is awarded to Dr. Anurag Krishna in the presence of senior dignitaries Dr. S.K. Biswas, Dr. D.K. Gupta and Dr. Nisar Bhatt. Dr. Anurag Krishna completed his undergraduate and postgraduate medical training at the prestigious All India Institute of Medical Sciences, New Delhi. He then joined at the University College of Medical Sciences, University of Delhi, where he started the pediatric surgical services and served the institution for over 10 years. For 1 year, he was a visiting fellow at the Royal Manchester Children's Hospital, UK, under the British Government Fellowship Programme. He has been very bright and he has been the most renowned pediatric surgeon in the private practice when he was at Gangaram Hospital. For the last 15 years, he has now been the chairman of the Pediatrics and Pediatric Surgery at Max Healthcare. He was for a period of 3 years the Group Medical Director at Max Healthcare, where he led the functions of medical quality, clinical governance, physician engagement and research across 12 hospitals. We have all seen the change, how Max has grown up, and pediatric care especially is really the best in the country at Max. Dr. Krishna has had a distinguished career and has held several important positions. He was a member of the Academic Council of the University of Delhi, nominated as a Fellow of the National Academy of Medical Sciences, which only few pediatric surgeons have been able to achieve. Till date, there are less than 10 of them. He was a member of the Board of Management at Gangaram Hospital and served on various hospital committees like Academic and Research and Ethics Committee. He has been a member of the Technical Advisory Committee for Pediatric Urology at the ICMR and Associate Editor of Indian Pediatrics. Dr. Krishna has published more than 60 scientific papers in leading national and international journals. He has contributed several chapters and has also co-edited a book, Surgical Diseases in Tropical Countries. May I welcome Dr. Anurag Krishna, please, on stage with a big hand of applause to you all. Welcome, sir. Please have a seat there. We'll honor you first and then your talk. Yes, sir, please sit here. May I request the dignitaries, please, to kindly come and honor Dr. Anurag Krishna, and may I request all those who are present here, online and offline, we are on YouTube, to please clap your hands wherever you are.
R. Krishna.
Thank you very much, Dr. Shilpa. Thank you, chairpersons, Dr. D.K. Gupta, Dr. Nisar, and Dr. Biswas. This is really an honor, and I'm humbled. The reason I'm extremely humbled is that this honor has been given to a person who, for the last 25 years, has been in the private sector. Traditionally, orations, research is a domain of the academic institutions. So I've looked at this really from the periphery. And to recognize me is truly a humbling experience. And I accept this honor on behalf of several of us in the private sector who are doing some good work and shall continue to strive towards excellence in pediatric surgery. The oration recognizes two luminaries. The first, Professor Upadhyay, my teacher, and teacher to a generation of pediatric surgeons across the country. One of the founding pillars of pediatric surgery in India. A teacher par excellence, a researcher whose work in splenic trauma still changes global practices. His innovation of the Upadhyay shunt was a low-cost intervention for thousands of children with hydrocephalus. A very able administrator because he set up a unit of pediatric surgery which was comparable to the best in the world. And a man of many facets, an artist, a poet, and deeply engaged with dramatics. I've had the privilege of working under him, and I've known him from very close quarters. The second luminary is Professor D.K. Gupta. I really don't know what to say about this man. His energy, his commitment, his confidence, and his sense of purpose truly is a lesson for each one of us. Single-handedly, this man has put Indian pediatric surgery on the world map. The who's who of pediatric surgery across the world knows this gentleman by his first name. And wherever you travel, you say you're from India, they want to know whether you worked with Dr. D.K. Gupta. So that's the remarkable quality of Dr. D.K. Gupta, and we all strive to follow in his footsteps. I chose this little topic mainly because, as I said earlier, my position was a ringside position for research in pediatric surgery. And a lot of what I will say are really views. Some of them may be motherhood statements. Some may actually be very forthright views. So you'll probably have to pardon me if some of them don't match with your views. We are here in this business of healthcare and also in research with a basic tenet of primum non nocere, or do no harm, to which I think the more important part is secundo facere bonum, which means we are here to do good. So just not doing harm is not good enough. We really need to be doing good in our clinical practice, and for the same reason, the same tenet should hold true for research that we conduct. We've been trained that research starts by asking a question, and then we build the study design to try and answer that question. But what I've noticed over the last several decades that I've been associated listening to presentations at meetings is oftentimes we work the other way around. We have a thought in our mind and we go about trying to prove that point by collecting data which matches our thought. And that may not be always the
best way of conducting research. And some of the reasons why we get into this kind of a conundrum is our pressure to be cited or referenced or published somewhere. And we've placed an undue emphasis on our publications for academic positions, little regarding the quality of publication that we may make. Over the decades also, there's been a glut of medical journals, so that has made getting our papers into journals relatively easier now. Across our country, we seem to be focused on research that is generating out of PG thesis. And that may not necessarily be the right way of doing good research, because unfortunately, PGs are there for 3 years, and to complete a good research project in that time may not necessarily be true always. And unfortunately, we rely heavily on retrospective data analysis, from which it's a good way to get information, but the scientific validity needs to be counter-checked by prospective studies. The ethics of research in children is ever so more important, and because they are a vulnerable group, and we need to be doubly certain that what you're doing is not only not doing harm, but also doing good. And therefore, the important tenet of the research should be guided towards an identifiable prospect of benefit. And the other important thing that I put up here is that whatever scientifically invalid studies that you may do, they are at the outset ethically inappropriate. One of the weak links in our research is this concept of informed consent. We always say the study has been cleared by the ethics committee, we always do an informed consent. Very rarely have I seen people take informed consent in the manner that it needs to be taken. And we cut corners, often citing lack of time, but I think that's the fundamental requirement of good research, is that the consent must be informed. Oftentimes we feel, oh, parents to gaon se hain, inko samajh mein nahi aayega, but that's really not necessarily true. Everybody has intelligence. They may not understand in the language that you say, but you need to turn it into a language that you understand very well. Oftentimes, I use the family test. What is the family test? Whenever you're in a dilemma of whether to do something for the patient in front of you, and you're not certain whether what you're doing is good or bad, stop for a moment and put that child in your family's environment and say, would you have done this thing if he was your child or your family's grandchild or whatever? And more often than not, that will help you in taking the right decision. And I think that's the important part of family test. It may not be scientifically the correct way of coming to decisions, but I think ethically, emotionally, and morally, that's the correct way of taking dubious decisions. I talked about glut of medical journals. And if you see across the last decade or two, the number of scientific journals, medical scientific journals, has significantly increased. We are now upwards of 50,000, out of which 30,000 are peer-reviewed, referenced in PubMed. So that's a huge number. We judge journals by the impact factor. And so I looked at the impact factor of the common pediatric surgery journals. And, is that a pointer? Doesn't work. The impact factor for most journals in pediatric surgery is not very encouraging. But then there's a flaw here, because the community of pediatric surgeons is small, and therefore the citation rate may not be as comparable to some of the other journals. When I compare this to the leading journals in medical sciences, there's a huge difference. NEJM is upwards of 100, Lancet is close to 100, PMJ, these are the three leading journals. So we are a long way off from there. But if you look at the impact factor of surgical journals, we are not doing so poorly, right? And I put these three slides up for another reason. How selection of data can create a bias. If I want to project pediatric surgery journals as doing very poorly, I'll compare the impact factor with the best medical journals, which means NEJM and BMJ. But if I want to project pediatric surgical journals as doing reasonably well, I compare it with the surgical journals. And therefore, selection bias happens in assessment of data. The other measure of scientific publications is the levels of quality of evidence. And the lower the level 1 is probably the best kind of publication that we have. Building on that, I picked up the most recent issue of Journal of Pediatric Surgery to see what kind of papers get published in our leading journal. There were a total of 28 articles. Needless to say, USA dominated the publishing region. Now, if you look at the study design, 5 of those 28 were basically education, training related kind of articles. There were 3 which were multi-center literature reviews leading to guidance. And all of these literature reviews were based on a systematic analysis of retrospective articles. So again, the import of these guidances becomes suspect. A majority of the articles, like I said, were retrospective cohort studies, and some of them were retrospective literature reviews. There were 2 animal studies, and only 2 randomized controlled trials, of which one was a product trial, and one was related to pediatric surgical trauma. So really speaking, where are we in terms of the quality of articles even in our leading journals? And if you look at the levels of evidence in these 28 articles, a majority of them were level 3, level 4 kind of evidence. So that brought me to think I'm paying 8,000 rupees for this issue, and look at the quality of information I'm getting. And that set me thinking of really where we are headed. In 5 of these articles, the author themselves stated that you need more data. If you know you need more data, don't publish that article till you have more data, isn't it? That makes common sense. One person says the findings are of limited value. Again, why did you publish it? So really the point that I'm trying to make is, towards the end, we will bring this. Fundamentally, are our researchers trained in basic research methodology? And that's where the relevance of societies such as this comes into play, is that we need to up our game on educating researchers on research methodology. I came across this series of articles in 1997, I think, in the BMJ, and that set me thinking. Trisha Greenhalgh has been writing extensively on this topic, and more currently she's been writing about evidence-based medicine. And when I first saw this in 1997, it set me thinking, do we really know how to read papers and assess their value before we change our practices based on what we've read in published journals? And so therefore I raised this little voice of caution, is before we change our clinical practice, be certain that where you get the information, is that information authentic, reliable, and reproducible. And oftentimes we lead, if we have time, I'll just give you an example. I think it was in 1981 that Alberto Peña published his path-breaking article on PSARP. And I still remember that article because it had very poorly drawn line diagrams describing how he did that surgery. 4 years later, in 85 I think, he came for a live workshop in PGI Chandigarh. And he was demonstrating his surgical technique, and I'm sitting in the audience as a young pediatric surgeon, surrounded by a lot of very senior pediatric surgeons. And the common murmur that I picked up from that audience was, "Arey, ye aise karte hain?" Which means these people had been operating on a large number of children in their own institutions, looking at that paper, and then realizing 4 years later that what they were doing was probably not the right way of doing PSARP. Imagine the amount of damage they've done to so many children by that time. So be cautious when you want to change practices based on what is published. The other big worry is the misconduct part in research. I mentioned to you about these 3 very leading journals in medical science. And look what the ex-editors of these journals had to say after they relinquished office. Richard Smith was the editor-in-chief of BMJ, and he wrote after he demitted office, "Health research is based on trust. Health professionals and journal editors reading the results of a clinical trial assume that the trial happened and the results were honestly supported. But about 20% of the time, the professor said that they would be wrong. As I've been concerned about research fraud for 40 years, I wasn't that surprised as many would have been by this figure." And he goes on to write, Stephen Locke, who was the editor-in-chief before Richard Smith, became worried about research fraud in the 80s, but people thought his concerns were eccentric. And research authorities insisted that fraud was rare and didn't matter because science was self-correcting, and that no patients had suffered because of the scientific fraud. So there was a concern from the 1980s onwards. The ex-editor-in-chief of New England Journal of Medicine writes, "It's simply no longer possible to believe much of the clinical research that is published or to rely on the judgment of trusted physicians or authoritative medical guidelines. I take no pleasure in this conclusion, which I have reached slowly and reluctantly over my 2 decades as editors of NEJ." Similarly, the editor of Lancet, Richard Horton, writes that the case against science is straightforward. Much of the scientific literature, perhaps half, may simply be untrue. And that should raise hackles with us and when we are evaluating scientific publications. The other little worry is what constitutes surgical innovation versus surgical research. Again, I reiterate the 2 basic tenets, but we did a little questionnaire evaluation of what the understanding of, this was with general surgeons, was regarding surgical innovation and surgical research. And look at some of those responses. A majority of them knew that there were national guidance which governed the ethical conduct of research. But a majority of them had never read those guidelines. And mind you, some of them, or many of them, were actually thesis guides for postgraduates for many, many years. the knowledge about whether innovative procedures were covered by these guidelines or not was also not forthcoming. Some of them had been doing scientific innovations, not knowing fully well that they were to have ethical clearances also or not. So there's a general lack of understanding of the difference between scientific innovation, scientific research, and we've seen some papers about these innovative surgeries which kind of over a passage of time have fallen flat, and in the process many children have been harmed. But I see a huge opportunity here, and the way forward is to look at the positives. As I see the current scenario in pediatric surgery, I think it's dominated by a lot of young blood. A majority of faculty across the country is in the age group of 35 to 45 and 48. And I think that's really a very, very important human resource potential that we have. Also, societies such as this are now getting activated to educate people about the benefits of good research. And the opportunity I see here are that we have probably the best and the largest clinical material or pool of patients in the world. And I would love to see a day where we actually dictate guidances about various clinical conditions. And we have the ability, we have the patient material, we have the infrastructure, we have the potential, human potential, and that's really the thing that we should be striving at. But what kind of keeps us back is collaborative work. No single institution will ever have that kind of patient population to deliver meaningful data and guidances that will stand the test of scientific scrutiny. But if we collaborate, and now as a starting point, this organization, also we have now, 24 AIMSs across the country. Let them begin, let them collaborate and bring forth data that we will all learn to respect going forward. Thank you very much for your patience.
Thank you, Dr. Anurag. That has been really mesmerizing. What a collection of information that you have shared, and to really caution all the scientists and the researchers in the group and how to conduct the research in the scientific way with the honesty and good collaborations. So I think we are also pleased to have your views on a topic that is so pertinent to this association and to this gathering. So on behalf of the chairpersons here, on behalf of the association, I have a great pleasure to compliment you on this subject, on your very lucid talk. So thank you very much once again.
May I request the chairpersons, President IAPS, President JNK chapter, Professor Gupta sir, and Madam, please join us on stage. We'll have a group photograph and present Dr. Anurag Krishna with a memento. Dr. Vijay Kundal and Dr. Akshat, please join us. Director AIMS Jammu may soon join us. Dr. Lucky, please join us. Rani ma'am, please join us. Sir is here. Sir, Acha, we are waiting. I request Shakti Gupta sir to please join us. A warm applause for sir, please. Shubhra ma'am, would you like to say something over sir's journey over so many years as a wife of a pediatric surgeon, what you have been through? Few words.
Good morning, everyone. Being a wife of a surgeon and more so of a pediatric surgeon is not an easy job. But I really admire the dedication, especially pediatric surgeons have, because they have great responsibility, and to some extent they're emotionally involved with the children because they have their own. And as his wife, I was more emotionally involved with his cases. I don't know if everybody else is like that, but yes, it was a tough job, and I'm very, very happy to say that my husband did it with great commitment, and I really admire him for that.
Thank you so much, ma'am. Thank you so much, sir. It's been an honor to have you here in AIMS Jammu. Thank you. So Dr. Indranath Verma will be joining us online. He is a professor of urology at the Institute of Liver and Biliary Sciences, Vasant Kunj, New Delhi. He belongs to Jammu, and this place is dear to him. He was supposed to join us in person, but because of a family wedding, he had to go somewhere else, but he's joining us online. He's an expert on urethral strictures. I have assisted him a couple of times. He does very good BRCA repair for deep urethral strictures, which are deep-seated. So we do only one layer, there he's doing it all in one go. So please, the stage is yours. Please share your slides. Yeah, we can see you. We cannot see the slides as yet. We can't see your slides. You'll have to share your slides. Doesn't matter. You can take 2 minutes.
Sharing.
We have your slides at the right in case.
Well, share content.
Can you see? We are sharing. We are sharing the slides. You keep saying next. Don't worry. Can you see the slides? Okay. So you keep saying next. We will do that. Is he audible?
Yes, yes. Okay, let me just try.
We can hear you, and your slides are visible here. You can start presenting, and when you want to change slide, you can say next.
Just 1 minute. So, you're presenting my slide from that side, right?
Yes, yes. When you want to change, you just say next.
I have done actually some changes, so no problem. I'll do. Okay, I'll just start from
Yes,
here.
yes.
Okay, I'm Dr. Inder. Ma'am has just introduced me. So I'm starting my presentation. Management of challenging cases of long segment stricture urethra. Okay, next. So stricture is the basically involve the anterior urethral part. Posterior urethral doesn't include under stricture, that comes under PFUPD. Is a narrowing of the urethral lumen, which is spongiofibrosis. Next slide.
May I request the chairpersons to please join us on stage, Dr. Anand, Dr. Prabhu?
Okay. So, you can see lumen is getting narrowed, and the associated spongiosum is also getting basically heavy pathology of spongiofibrosis. Next, please. So symptoms are obstructive, bleeding, recurrent UTI, retention, all those are the symptom of stricture, apart from infection. Next. To diagnose the history, imaging study like RGMCU, ultroscopy, at time require a sonogram and also MRI in challenging cases. Next. options depend on the size of stricture, kind of stricture. For short segment, conservative management, dilatation, endoscopy, OIU, jutsu stenting, and at times anosmotic justoplasty are required. But for long segment and complex structure which are recurrent, we have justoplasty, flag justoplasty, or the stage justoplasties, which are the kind of graft, flap, and the mix of these things. Next, please. And osmotic urethroplasty, just before I start for the long segment, just overview. We excise the short segment and anosmos primarily by using 3 or 4-0 white club. Next, please. Next. Yeah, this is a depiction. We excise the stricture spot and ends are spatulated and being anosmosed. Next, please. Next. Yeah, this is the photograph. Okay. Now the management will come to the main thing. This is a photograph of osmotic urethroplasty. So now we focus on long segment and complex strictures. By definition, while long segment is anything more than 2.5 centimeter and complex strictures are recurrent or having different orbital variations. They are meant by graft urethroplasty, stage urethroplasty, and the flag urethroplasty. Next, please. Yeah, graft urethroplasty, we use the graft for long segment. We excise the structure and cover with the graft, or we just expand it without excision. These are the techniques. Next, please. Yeah, the harvesting of graft is mainly from the buccal mucosa. At time when buccal mucosa are not good, we are using tongue. But also, the little part of the tongue, which is free from the taste bud, can be safely utilized. This is as good as even better than the buccal mucosa in my experience. Next, please. Yeah, so we use this graft augmentation. Here we just augment without excising the stricture spot. Commonest graft again, the buccal mucosa, lingual, rarely bladder, full thickness, rectal, pedicle island can be used. Next. So, depending on the technique, we can use only urethroplasty, inlay, or combination of both. Like combined ventral onlay and dorsal inlay, which is a palmetry technique given by Enzo Palmetry. And the other is the ventral inlay and dorsal onlay given by Dr. Sanjay Kulkarni, one of the Indian pioneer of urethroplasty based in Pune.
He's a pediatric surgeon, by the way.
He's I think urologist, Dr. Kulkarni. I'm not sure. Maybe
we are sure he's from our college. We are sure.
Okay, okay. So only technique, we just lay open the stricture and put a graft on the outside, not the inside. Next slide. Okay, so most commonly technique used only is ventral, only urethroplasty. So on the ventral surface, we do the structurotomy, clean up and put a graft and do the anosmosis for the long segment. Next, please. Yeah, this is the photograph typical on the ventral part. This buccal mucosa graft has been put. This takes care. Next. This is one of the most commonly technique. The benefit of ventral only is that the patient had a previous OIU or some urethral surgery stricture, then it's better to manage. And then the stricture is usually on the 12 o'clock. Now the OIU has been done at usually at 12 o'clock. So we get a very good field and very effective, especially in post-OIU setting. We can have the good vascularity in the dorsal surface, which is not disturbed. Next, please. Yeah, other technique is dorsal only urethroplasty, where is basically given by probably Italian legend in urethroplasty, again modified by Dr. Sanjay Kulkarni. He is also doing the later on instead of dorsal, Dr. Sanjay Kulkarni. In the dorsal, we lay open, put a graft, it has very good bed and can be done. Only problem is in OIU setting, where is quite adherent. So for OIU, post-OIU, we should use bento only. Next, sometimes there are the situation when the, this is the dorsal on the urethroplasty photo. Next, please. There are the things sometimes basically structure is very, narrowed and we require combination of excision of structure and put in graft. This is called augmented and osmotic urethroplasty. Do the strip roof or floor, then put a graft on one side. One side we excise the structure, one side we put a graft. I'll show you next slide. Next, please. Yeah, this is a depiction. We have just excised the structure. Next, please. So actually, a photo or a graph has been skipped because I couldn't update and I updated it with me. Anyway, so now that this is real thing. When the structure is quite, pan-urethral, hardly any lumen is left, then we have option of either opening through that space like Johnson, or we can do double dressing technique. We can combine this kind of grafting on the ventrals and dorsal both sides, either by parliamentary technique or Dr. Sanjay Kulkarni technique. Combined ventral inlay dorsal or ventral only or dorsal inlay. These are actually very effective, which helps to do the surgery in single stage rather than multiple stages like Johnson. Next, please. Next slide, please. So basically, parliamentary technique. Okay, you can keep this, no problem. I'll just explain. We can, please next slide. Here, this is a parliamentary technique. We have opened ventrally and putting the graft inlay, dorsal inlay on the inside. Then we are closing, putting graft on the outside, ventral only. And this is the final picture. This tackles the severe form of stricture which can be managed. And good thing is that the dorsal support is not disturbed, and vascularity is maintained, and good uptake of graft is there. Next, please. And the patient just give the history of why you all that, then we will prefer Kulkarni technique. This ventral inlay and dorsal and onlay. We use it. Next, please. So, other thing is that one is not sure of using double breasting. He feels still patient lumen may be compromised, all that. So, options are stage urethroplasty. We just lay open the structure like Johnson technique. I'll show you next slide. And next, put a graft or without graft, and then retumorize after 6 months. Next, please. You can use a pedicle graft for that. Yeah, this is Johnson stage 1. It had penile structure. It has been laid open. And had it been the bad structure, at the same time that the buccal mucosa graft can be put. Next, please. If we just, after 6 months, recanalize use the local skin adjacent, and we can also use the ventral urethroplasty like Snodgrass procedure. If it's tight, or we can also use a graft. This is stage 2 urethroplasty, the stage procedure. Next. The third option I am discussing, the flap urethroplasty. Here are also indicated complex structure, pan-urethral structure, recurrent structure. The local flap of the penile urethra can be used, but the contraindication is VXO. When there is inflammation like sclerosis or VXO, the penalty is 0. Typically trends is there. Then the local flap is contraindicated. Next, please. We can use this other thing like local skin. If skin is healthy, ventral longitudinal island, which is basically based on dartos, like same way we use in hypospedia, this can be used. This is unique thing, can be used in pediatric patient as well as the adult patient. This gives good result for the long segment. Next, please. The ducket island, again, we can use the dartos tarsal flap for the penile stricture, and this gives very good result. Next. For other stricture like subcoronal, all that, we can use ventral transverse island, same way we use in hypospedia. This flap only is very good. Next. Yeah, this is the most commonly used in urology, any circumcoronal penile skin flap urethroplasty. We use on the skin basically rather than this dartos. This is useful for the long almost a pan-urethrostricture where the anterior thrice involved. Only the contraindication is local BXO or lichen sclerosis, what we call. Otherwise, this is a good option. Next. So basically, there has been meta-analysis by Vassar we showed if we select a good patient, both graft as well as flap, they give almost equal results. Only graft procedure have a better result than tubulized graft because in tubulization the chances of leakage are more. Same way you guys experience in hypospedia surgery. If we do not just tubulize, we get a better results. And usually we, for the proximal reconstruction, graft are used, and for the distal reconstruction, flaps are used. And the double breasting, urethroplasty, kulkarni, or palmetry, they are very useful in extensive strictures, challenging cases, where we have to think of two-stage procedure, which can accomplish in single stage in most of times. Next, please. Yeah, this was my presentation. Unfortunately, there were some changes done. Photograph was included, but because of technical problem, I couldn't show you. So, if any question I can answer, I'm not able to hear from that side.
We are able to hear you.
Okay, any question? I'll answer.
I hand over to the chairpersons.
Thank you, Dr. Verma, for this comprehensive talk. And you have given a very nice overview of the management of the long segment urethral strictures. The house is now open for the questions.
I think Manish, you have to come here because he may not be able to hear. It's connected only to this laptop. Okay, any questions from the audience? Yeah, Dr. Lucky. I will repeat whatever question is asked.
Good morning, sir. Sir, you have described circumcoronal penile skin flap uterus.
Lucky, you can come here, I think, to save time.
Good morning, sir. Sir, you have described circumcoronal penile skin flap urethroplasty for long segment bulbar urethroplasty. Is there any fistula?
Yes, madam.
Is there any fistula formation in these cases while using the skin flap urethroplasty, or any complication?
Yes, ma'am. In pediatric patient where basically the size is less, all that, the structure length, we get some fistula formation. But adult patient with properly size and there's no BXO, the chances are very less. Only in my cases, I have done around 12 MAC image. I got fistula in 2 cases. So their results are almost comparable to hypospadias.
Okay, sir. Thank you, sir.
One question from my side, or just for the benefit of the audience. I've seen you doing these double-breasted urethroplasties and double sides grafts.
So what is the diameter that you take, because you had taken quite a wide diameter compared to the urethral size?
Yes, ma'am. We use the caster size. We try to keep around 18 French. So we use a scale. 2 pi r is the basically circumference. So say 18 French is 6 mm. We should keep the diameter of that graph should be 2 centimeters so that we can have a wide tube. So consider the actually native healthy remaining segment of the urethra, and accordingly we'll just add the segment on the both sides so that we get a good lumen of circumference of around 1.8 to 2 centimeters, so that a caster of size of at least 16 French or 18 French can be kept without any kind of problem of constriction. Of course, they do dilate by 3 weeks when we contemplate to give a trial with the catheter after doing the pericaster study or MCU.
And the approximation of the cavernosas above the urethral tube that you did, spongioplasty, to cover so that there was no fistula formation.
Yes, ma'am. We use the same principle like hypospadias, use the buccal mucosa with the urethral mucosa. Then second layer is the spongiosum. Use the spongioplasty. And if it's deficient, we can mobilize the surrounding tissue. And third is subcuticular and the skin. Fourth, really, we can also use the barrier flap from the scrotum, tunica vaginalis. We find we are not covering sufficiently. So basically, it's more or less like hypospadic surgery. There is some relaxation. We are not much bothered about the fistula using the graft, but we use the flap like ducket, the neck, and niche, all that. We have to very precise in suturing. Use 5 or 6 0 suture. Try to be as meticulous. At times we use this loop. Almost the same thing, but in adults we really get the problem with graft, because especially early their accident.
Thank you so much, sir. So the take-home message I take from his work is that we should not hurry up for urethral strictures in the childhood. Wait till puberty, the tissue really grows. Their spongiosums are so thick that there is no chance of fistula. We are able to give a 2 centimeter diameter of the urethral tube, which later on shrinks to get the adequate size. So without complications, you can have a patient. So if there's a patient with urethral stricture, post-trauma or any other cause, you can leave the patient on SPC with cycling of the bladder, and then later on when he grows up, puberty comes in and the tissue grows, you can have a good urethroplasty in one stage with very good results. Excellent results, means the uroflowmetry of the patients are just too good. Any questions from the audience? Thank you, sir. A big hand of applause for Dr. Verma.
Thank you.
Thank you. We're logging off from here. Your memento we will deliver you at ILBS. Thank you so much, sir.
Thank you, ma'am.
Thank you, sir. Thank you, madam. Before proceeding, thank you, sir, for your gracious presence. Before proceeding to our next session, may I now request Dr. Vijay Kundal, Organizing Secretary of the 9th Annual Conference of Research and Innovation in Pediatric Surgery, to present the customary contributions from the registration of this conference to IAPS and REPS. May I request Professor Dr. Sumitra Kumar Biswas, President IAPS, to kindly come on stage. Thank you, sir. I request Professor Dr. Shilpa Sharma, Chairman REPS, to kindly accept the contribution. Sir, Thank you, sir. Thank you, ma'am.
Some of us may have to go, so we just, yeah? Dr. Sublai, okay. A big hand of applause for AIMS Jammu. It has been a really wonderful conference, and please carry on. The sessions will continue.
Thank you, ma'am. Moving on to our next session, titled Pediatric Solid Tumors. May I now request the expert speaker, Dr. Abhinav Chaudhary, Senior Consultant, Narayana Hospital, to kindly come on stage. Thank you, sir.
Thank you to the organizers and especially Dr. Vijay Kundal for inviting me. I am Dr. Abhinav Chaudhary, Consultant Surgical Oncology. I'll be presenting management of pediatric solid tumors, a surgical oncologist's perspective. Greetings from Sri Mata Vaishno Devi Narayana Hospital, Katra. Jai Mata Di. So these are the most common pediatric solid tumors. Neuroblastoma constitutes 7% of all pediatric tumors. Wilms tumor, bone sarcomas, rhabdomyosarcomas, and hepatic tumors. It is not possible to do justice in 15 minutes to cover all these topics, and I am going to skip the molecular part because Dr. Shabab will present that in the subsequent lecture. And I'm not going to present any latest papers either because it's just not possible. This is just an overview. So we'll start with the neuroblastoma first. It is the most common pediatric solid tumor and the most common abdominal malignant mass in children, and the median age at diagnosis is 18 months. It is basically a tumor of the sympathetic nervous system, and 75% of abdominal tumors are primary to the adrenal gland. So coming to the historical perspective, in 1959 we have one of these reports. And in 1959, they were, out of the 217 cases, Gross et al. Reported that they were able to perform a complete resection, which was probably R1, in 22 children only. And in the stage 4 tumors, they recorded a survival rate of only 6%. And they also observed one case of spontaneous regression. So this is one of the tumors which undergoes spontaneous regression. Coming to the imaging part, CT scan, MRI and MIBG scan are used for the diagnosis. I'm not going to go into the details of the imaging. And these are the staging, which is divided into the staging at diagnosis, which is the pre-operative, and the post-operative staging. But more important than that is the risk stratification, which is based on staging plus age, extent of disease, microscopic appearance, and genetic features, which include DNA ploidy, surgery, radiation therapy, and in some cases, bone marrow transplant. So, what I want to convey to the audience, especially the young surgeons, that only an R1 resection can be achieved in most cases. So, when I was also a young surgeon, and I thought, okay, maybe it has to do something with the competence of the surgeons, but that is not actually the case. Neuroblastomas are highly infiltrative tumors, and actually it is not possible to do a complete microscopic margin in these cases. So the aim is to do an R1 resection because of the infiltrative nature. And the goal in most cases is to achieve an R1 resection. In cases of intermediate and high risk cases, even an R2 resection is acceptable. So this is what in general from my view is in neuroblastomas, that you don't have to do something heroic. The disease is extremely infiltrative, and no matter what you try, it is possible to leave some disease behind. And we are not trying to do something heroic here because of the nature of the disease. Coming to the Wilms tumor, it is the most common kidney cancer seen in young children, and it is the second most common abdominal malignancy. Historically, if we go back to 1932, only 22 of 30 kidney tumors in children with average of 2.5 years were considered resectable at that time, and the overall mortality in Wilms tumor at that time was reported as 21%, and the 2-year cure rate was 10 to 12%, and the rates of long-term survival were no more than 25%. So this is, we are talking in the 1930s. In 1938, Ladd emphasized the importance of fluid resuscitation, blood transfusion, and good vascular control, and he reduced the mortality to 7%. However, long-term survival was still less than 25%. Subsequently, Gross incorporated post-op radiotherapy and improved the overall cure rate to 47% and 80% in those younger than 12 months of age. Faber subsequently incorporated actinomycin D chemotherapy, and currently the overall survival for patients with Wilms tumor is 90%. So we have come a long way since. Imaging is greatly improved by the CT scans now, and early diagnosis is of course possible with ultrasound only. This is the staging, this is the shortened version. I won't go into the details of that. So coming to the surgery, the importance of regional lymph node sampling is very important, because it gives us the prognosis of the disease and the outcome of the disease. If the disease has gone into the lymph nodes, the prognosis is poor and the outcomes are poor. There is emphasis now on nephron sparing approach for bilateral tumors and those arising in solitary kidneys, and use of neoadjuvant chemotherapy for Wilms tumor in which there is major vascular infiltration. So primary resection for a Wilms tumor include a laparotomy, a radical nephrectomy, and regional lymph node sampling. Here I would like to emphasize that this should be done by surgeons who are experienced in Wilms tumor nephrectomies. Personally, when in my current institute, we don't have a well-developed pediatric oncology department, so I don't do this surgery anymore, and I refer it to pediatric surgeons.